We're really privileged to have Dr. Michael Mack here. Michael Mack's a fascinating guy. Just a quick story is my first ISMICS meeting was in Munich, and I didn't know much about it. Some claim I still don't. But I heard this guy speaking, and I was so impressed that he knew more. I thought he knew more about the cardiology trials than the cardiologist did. And I said, this must be a really cool organization. I gotta join and keep coming to these meetings. And that was really how I started getting involved in ISMICS. And I should have known that because Michael Mack actually trained in internal medicine and was board certified in internal medicine and then completed his surgery in Texas. But he did his undergraduate right here in Boston at Boston College. And he's gone on from being president of ISMICS in 2000, 2001 when I heard him speak in Munich. He's also president of the Society of Thoracic Surgeons. He's done something incredibly innovative in that when TAVR was being introduced, he actually got together with David Holmes, then president of the ACC, and the two of them together said that the two societies would work together, publish consensus documents, negotiate with CMS, and create the TVT registry, which is based on the STS and the ACC NCDR. And put that together. And it is that type of collegiality and bridge building and working together that allows innovation and future development. So with that, I'd like to welcome Dr. Michael Mack, and I'm sure we're going to have a great time listening to him for the Kit Arom Lectureship.
Well, Francis, thank you for that very kind introduction. It is interesting, since I was president of ISMICS in 2000, the way that you don't anticipate that paths will lead you. And I guess I did know something about cardiology trials because I just came here from Washington, where I'm on the board of trustees of the American College of Cardiology now. So I've crossed to the dark side. And that's an interesting endeavor in and of itself. So it's an honor and a privilege to give the Kit Arom Lectureship. But ISMICS is all about innovation, and thinking about what to talk about here, I looked to the ISMICS mission statement that says it's committed to lead and promote innovation and technological advancement in cardiothoracic and cardiovascular surgery through scientific analysis and education. So what could I say that's not preaching to the choir, that already gets this and understands this and is all about innovation? So I looked at it this way. Now looking back, what would I have done differently, and what have I learned on this journey about innovation? And hopefully some of the lessons I've learned and the mistakes I've made and the things I've learned the hard way, I can spare some of our younger folks from doing. So this is my conflict of interest disclosure. I'm on the steering committees of two trials, of Edwards Life Sciences and Abbott Vascular. Unfortunately, I am uncompensated for both. And it is, like I said, an honor to stand up here and to give the Kit Arom Lectureship. Kit was a great friend, a great innovator, a great colleague, very much on the cutting edge of surgery, and a very, very strong supporter of ISMICS. And this is, a lot of us have our own different memories of Kit, but this is one of the ways I've always thought about him. I would also like to acknowledge and recognize what I view as the founder of ISMICS. There are a lot of folks there at the beginning, but it was Bob Emery's vision, foresight, work ethic, stick-to-itiveness that actually got ISMICS together and going. And Bob, we all owe you a debt of gratitude for what ISMICS has become today. And I would also like to thank Francis for asking me to give this lecture. It truly is an honor. I go to a lot of society meetings now, and to be able to come back to ISMICS and to see that innovation is alive and well and percolating is just refreshing. Just the time I spent around here yesterday afternoon and this morning has been totally refreshing, that innovation is alive and well in cardiac surgery. So this is what Francis was referring to. Is I was the third president in 2000-2001 in Munich. And you can see that the list of presidents and past presidents there. And I certainly have changed some from this picture, a little bit sobering when you look back and see what I looked like back then. So the themes of the talk is kind of what helped me get through this pathway of innovation and to where I've gone with my career, and what I wished I had done differently. Looking back, how could I have done it better? So what helped me? Well, I think there's three things that I think is mandatory reading for anybody that's in the field of innovation, and especially in cardiac surgery. And the first is this, the presidential address of Toby Cosgrove, called The Innovation Imperative, that he gave in Toronto in 2000. And I can still remember sitting in this audience like it was yesterday, of saying, this guy really gets it. And I must say, I've gone back and I've read this presidential address 4 or 5 different times over the years. And there's many quotes that you can take out of it. But it was a refreshing look, and I must say really stimulated me to think differently than the way I had before. So if you haven't read this, or if you haven't read it recently, I would encourage everyone to go back and look at it. The second, and I'm sorry I missed Rory McDonald's talk yesterday, but talking about disruptive technology. But this is kind of the Bible, the Clayton Christensen Innovator's Dilemma. And if you haven't read this, it would serve you well to go back and understand how new technology is introduced and leverage off of the talk yesterday. And then the third is Outliers by Malcolm Gladwell. As a matter of fact, anything that Malcolm Gladwell writes, there's major lessons for all of us there. And the number of times I've gone back and reread sections of this book has been extremely helpful to me. The second thing I would say is, don't be limited by what you think you know. And I think sometimes as cardiac surgeons, we know all the reasons why things can't work or shouldn't work, and it impairs us from thinking outside the box. And I'll just kind of give this example. Does anybody know who this is standing with me? Anybody at all in the room? I met this gentleman a year ago for the first time, although I'd heard about him for over 10 years. It's Henning Anderson. Does anybody now know who he is? So he's a Danish cardiologist that invented transcatheter aortic valve replacement. And it's an interesting story how he did it. So he was in 1992, went to Phoenix to Ted Dietrich's meeting on EVAR, on stent therapy. And he was flying back home from Phoenix to Copenhagen, and literally on a napkin on an airplane sketched out the concept about why can't you put a valve inside a stent and do transcatheter valves. So he went home, and the way he tells the story, it really was a collaboration with surgery, because you see the stent that he has here? This is surgical steel wires that we close sternums with. So he went to the operating room with his surgeon, got surgical steel wires, went to his garage, crimped them in this manner, and then tied a valve on it. You can tell a cardiologist did that. Those are not surgical knots, but be that as it may, this was the first transcatheter valve. He then mounted it on a balloon, filed a patent for it, which was issued in 1995. These are the designs in the patent. And these are the patents that are the subject of the recent billion-dollar settlement between Medtronic and Edwards. And the interesting part of the story is 20 years after he had this idea on an airplane, this gentleman got a TAVR valve. It's his father. So, I mean, how cool is that? Somebody comes up with an idea, and 20 years later, their own family member is treated by it. So, but it's interesting. It took a cardiologist to do this because, and I've said many times over the years, I don't apologize for not having invented this, because I was thinking, I know all the reasons this can't work. Well, you got to cut out the old valve. How do you do that? Well, all the stuff is going to shower to the brain. It's going to occlude the coronaries. Well, you know what? Yeah, all those were issues, but not so much. And they really didn't happen. But this thinking outside the box and thinking of ways to do it, I think is a major lesson for all of us. The other thing that's helped me is cross-fertilization is key. And in 2001, I wrote this article for the Millennium issue of JAMA on minimally invasive and robotic surgery. Now, the initial person that was asked to write this was Robert Guyton. And this looked at all areas of medicine and trying to predict what's going to happen in the next 100 years. And Robert didn't feel he was qualified to do it and suggested that I do it. Well, I wasn't qualified either, but I didn't know how to say no. And I said yes, and then said, how am I going to do this? I'm pretty clueless as to how to write a paper like this. So I knew enough people in enough other fields, and I went to people in other fields that I knew. So laparoscopic surgeons that had actually helped us with thoracoscopy was getting started, orthopedic surgeons that I'd worked with, spine surgeons, urologists, plastic surgeons, ear, nose, and throat, and just kind of asked them to try to predict the futures of their specialties and how surgery was going to go. And it's remarkable that the same 4 themes came through over and over and over again. That the future of surgery was going to be ablation over excision, image-guided over visual, reconstruction without suturing, and access via natural orifice or blood vessel over incision. And indeed, this was written in 2000, published in 2001, and then what happened in 2002? A TAVR came about. And when I wrote this, I again, would not have even thought that you could replace an aortic valve percutaneously. But 3 of these 4 themes all are encompassed with transcatheter aortic valve: image-guided over visual, reconstruction without suturing, and access via blood vessel over incision. So that was a major lesson to me, and it didn't take long to connect the dots as to what was going to happen here. So this is Frederick Moore and myself in Leipzig, where Goethe wrote Faust, and Mephistopheles still lives in the basement of beer halls there. And we made a deal with the devil, and the devil was Alain Crebier, who was the cardiologist that did the first transcatheter valve in humans. And that's what started Tommy Walther on the road to transapical aortic valve replacement. And so I had lived through this before, having seen percutaneous coronary intervention, what it did to surgery, and was asked by Larry Cohn to write this editorial: "Fool me once, shame on you. Fool me twice, shame on me." So it did allow me to think differently and to say, certainly there can be a better way of introducing this into clinical practice than the way it did the first time. And one of the key concepts into this that I know everybody knows here well, but it's worth repeating, is that less invasive beats more invasive every day of the week. It's like baseball, where tie goes to the runner. If a less invasive procedure is not inferior compared to a more invasive conventional procedure, then by definition it is superior. You know, it's I think it's seen over and over and over again. So what road to follow? Sometimes it kind of seems like this, but I think there are some milestones or some key concepts going forwards. The first of all is imaging is king, and we're on the cusp of an explosion in what's happening for imaging. And both from a diagnostic and pre-procedure planning and assessment to image guidance during an intervention or surgery to post-surveillance. And I'd just like to give a couple examples of each of these, of the role of imaging. So this is now 4D CT scan reconstruction of what we can see anatomic-wise. And I think everybody needs to have a stronger background in imaging than we have as surgeons, but just begin to think what is possible now that we have these ability to see inside the heart and see inside the lungs and be able to plan procedures, and I'll show you an example of this in just a minute. So again, you see that the aortic annulus is a dynamic structure, not a static structure. And now as we go to 4D with incredible software rendering, we're so much more sophisticated than we were before in terms of what we can do. So look at this, and I'm going to mention in a couple minutes what's happening in transcatheter mitral valve replacement now. But can you imagine the pre-procedure planning, and with technology that's coming about, I think truly percutaneous transapical procedures are about to be upon us. And it's not the aortic valve, it's more the mitral valve. And oh, by the way, look at the left atrium that you just see right there. What great new ways of ablation of the left atrium are going to be available by percutaneous transapical abscess that are going to be much better, potentially, than transseptal approaches to the left atrium. So this is a 3D rendering of the mitral annulus right now that's being used for percutaneous mitral valve repair procedures. So this is what Francesco Mazzano is using for the Valtech procedure, the Cardioband procedure, of sizing it, the length of the band that he needs ahead of time and how much he's going to shorten it. And this is 3D placement of the Cardioband. There have now been 25 of these procedures done worldwide. Here shows the Cardioband in place and cinching of it to correct mitral regurgitation. So this is an example of a patient with ischemic mitral regurgitation, and now with incredible 3D rendering, you basically can place a MitraClip within a millimeter of where you need it to in order to do it. I mean, it's incredible what's happened just in the last few years. And here now are methods of post-surveillance. So here's a coronary stent in place. And look what you see inside this stent. Can you just imagine the other potential applications of 4D rendering now by CT scans and fusion technology of echo and CT together, which is happening real time? So what's helped me on this path? Well, I think first of all, gaining experience in another field. And I know this is hard to see, but believe it or not, I'm actually an author on an atlas of endoscopic spine surgery. Hard to believe I knew enough to have an atlas on that. But that's from years spent working with the spine surgeons on endoscopic approaches to spine therapy. And there are a lot of lessons I took with that. The second thing is probably one of the biggest shortcomings I see again and again and again is the inability to folks to write a good scientific paper. And so this was one of the first papers that I ever wrote in 1992. And I must say I was clueless as to how to write a paper, but there's one person that helped me that's not even an author on it, and that was Rod Landreneau. So Rod spent, at the time, you know, you had to exchange things by fax. And the corrections that he made on my paper and the time that he spent helping me how to think in a way that communicated it was a debt that I owe him to this day. And I think that if I spend more time with all our junior folks doing anything, it's how to think structurally and how to write a scientific paper. And I think to this day, I mean, even folks that you think should be able to write a paper well don't do it. And I think we struggle with that more than anything else in our institution. So I would encourage everyone, you know, it's when you write a paper, you're telling a story. And some of the folks that that excel at this actually have had a creative writer help them figure out how to tell their story scientifically. The second thing is public speaking, and I know everybody in the room speaks in public in their institutions, in their cities, and at meetings, but there's some interesting aspects to it. So as Francis said, he heard me speak when I was president of ISMICS in 2000, and he said he thought that I did a pretty good job and that I'd learned. And that he learned something there. Well, I thought I actually did a pretty poor job. I mean, I was pretty disappointed in it. And I've had 2 more occasions to give presidential addresses since that time. One is at the Southern Thoracic in 2009, and then the Society of Thoracic Surgeons in 2011. And I was so disappointed in my performance that I went out and found this guy. So this is a speech coach. And he's an actor in Dallas. And what he does is in his day jobs is he is the coach for the CNN anchors of how to, he consults with CNN to teach the anchors how to relate to an audience. His other daytime job is his major clients are plaintiffs' attorneys. He teaches them how to relate to a jury, to how to get their message across. And so one of the first things he said when I met with him, and I actually found him through an attorney, was, well, I've helped a lot of cardiologists and surgeons over the years. Do you know a guy named Clyde Yancey? And so Clyde Yancey was president of the American Heart Association. I worked with him for a number of years. I always thought he was the most incredible speaker. He's a black cardiologist that is that you think he's a Southern Baptist preacher. I mean, I was always disappointed when I had to go up after him because I thought he was so great. He says, yeah, I spent years working with him. I thought it came naturally to this guy, and it didn't. He had a speech coach all these years to do it. And everybody that is public speaking has a speech coach. It just doesn't come naturally. So there were a number of things that he said to me that stuck with me early on. And first of all, it's never about me. It's always about you. The most effective people listening in an audience have to feel that somehow they're better off when they walk out of the room. And it's never about me and what I accomplished and what I did. It's how I can somehow help you feel like you've learned something in the time that you sat here. And so that stuck with me. The second thing was he had me read this book called Beyond Bullet Points. And it's how to speak without PowerPoint. You know, we get so focused on PowerPoint that the media does become the message instead of being the vehicle in which to deliver the message. And it's very helpful to be able to figure out how to construct a talk, how to put slides together. Less is more. And so it's worthwhile reading this book by Cliff Atkinson. The third person that helped me, believe it or not, is this guy. So I think everybody in the room should know who this guy is, even if you aren't from the United States. But this is the owner of the Dallas Cowboys. And I've had him, I've taken care of his family over the years, and I've had him give a number of talks for me. And he comes into talks totally unprepared, and he just has one question. What's my audience? Who am I speaking to? And you tell him that, and then he goes in and wings it, but he delivers a message with the same themes, but very effectively, totally adapted to the audience that he's speaking to. So all of us tend to kind of give the same talk, and we speak in the same language and give the same message, no matter what venue we're speaking in. But you got to realize that you're speaking to different audiences, and when it's mid-level providers in your hospital, it's a different talk than it is to your county medical society or to a talk at ISMICS, and you have to adapt. So those are kind of some of the things that has helped me. Working with industry. So this is something that has always been viewed as tainted, that somehow we have to keep an arm's length from industry. And it's going to become more of a deal in the number of months coming up because the Sunshine Act goes live. And right now, companies are obliged to publish on their website monetary money that's gone to physicians. Well, starting the fall, this will be on a government website. And just like the CMS publications of money paid to physicians in the United States, this now all is going to be widely available to the public on the CMS website. And it's starting in August of 2013 is the data that's being accumulated that will be published in the fall. And this is going to bring us under greater scrutiny of our relationships with industry. But I must say, I think we need to be defensive and offensive about this, because I don't think we can do what we do without relationships with industry and without being proud of it. And sure, there have been abuses that have happened. I think we have to be cognizant of those and minimize the abuses. But the role that industry plays in what we do, I don't think we should feel guilty about by any means. And I'll just kind of use a couple of examples here. So this is the Syntax trial, which was drug-eluting stents versus cabbage, that was sponsored by Boston Scientific, that spent about $125 million on this trial. And there were two people in the rooms 4 times a year over 6 years in multiple hotel rooms throughout the world running this trial. And we ended up becoming the president of the American College of Cardiology and Society of Thoracic Surgeons. And Francis has outlined some of the things that have happened because of that relationship, including this heart team of cardiovascular care. But unless we had a relationship with industry, which did this trial, all these things that we think are good from a professional society standpoint wouldn't have happened without the conduit of industry scientific trials in order to do it. The same thing with the partner trial of Edwards Life Sciences, of multiple meetings over the years of collaborative together that has turned out into 4 New England Journal publications. Well, this wasn't done out of academia. This was done by the sponsorship of industry. And I think, again, we need to acknowledge that relationship. We need to be careful and be stewards of a positive relationship and avoid the abuses of it. But to think that we can do this alone without industry and that somehow we should be shameful of that, I think is totally wrong. As I said, I'm on the board of the American College of Cardiology right now, and my disclosures here, even though I haven't taken any money for it, is considered a relationship with industry, and it's going to impair me about advancing in the American College of Cardiology because of that relationship. Well, I think of, so be it. Those are the rules of the road, and it's going to be what it is going forwards. But I just think that my relationships with industry over the years has served me and our specialty well. So what are do-overs? What are some things I would do differently? Because not everything has gone perfectly. Well, there are some lessons learned. And the first is, don't do a randomized trial too early in the introduction of a new device into a specialty. And that timing is everything. There can be great ideas, but it can just be the wrong time in the milieu in which it's introduced. And just because it's new doesn't necessarily mean it's going to work. And there's a lot of new things that I was enthusiastic about that turned out to be busts. So first of all, never do a randomized trial too early, or for that matter, too late. You have to have equipoise about new and old technology, and there's a window on which this can be done. If you do it too early, it's not fair. If you do it too late, people are convinced they know the answer, and there's not equipoise and you won't enroll. So I'll use this as an example. This is VATS lobectomy. And Rod Landreneau and I, along with two folks from the Cleveland Clinic, Tom Kirby and Tom Rice, did a randomized trial in 1995 of VATS lobectomy versus muscle-sparing open thoracotomy. And it was a negative trial. And it was a negative trial because it was too early in the technology. We probably didn't have the right trial design. And we had two non-believers in this. Now you can say we did have equipoise because we had two believers and two non-believers, so we had perfect trial balance in this. But the point is, we did this too early in the introduction of this technology, where VATS lobectomy was still in its infancy. There weren't the same tools that were developed then as there are today, and I must say, I think we set that procedure back 10 or 12 years just by doing this study at that time, and that was a major mistake that we made because it very much impaired the development of it and the adoption of what I think is a very worthwhile procedure. Second, timing is everything. And so I showed this before, but this is the MitraClip. And now with 3D echo, it's very straightforward to place these within a millimeter of where you want to. But this was introduced in 2001, and for the first 8 years of the technology, 3D echo didn't exist. I think that this technology would be totally different today if 3D echo had been around at the time the MitraClip was introduced. And indeed, I think MitraClip is going to be eclipsed by a number of other mitral technologies right now that are taking advantage of 3D echo. Here's another example. Robots doing heart surgery. This was National Enquirer, I think, then. And if you don't recognize who's doing this surgery, it's Ralph Damiano that made the cover of the National Enquirer. So Ralph and Herman Reichensperner and myself spent a lot of time in the late 1990s doing robotic surgery. Well, you know, we got a couple things wrong. One is our timing was wrong, and two is we had the wrong robot to begin with. And thirdly, I didn't have the persistence anyway to see through it. Now, I think we're at the stage today where robotics is a very positive contribution to it, but here was a technology that was too premature, and we were doing it too early and trying to do too complex procedures before the technology was there. There's another. With Hani Shanib, we actually came up with a device, an anastomotic connector, to connect two blood vessels together. And this actually was a great concept. We actually got to humans, and it actually worked. But what happened is this is a space that the money dried up, in venture capital money investment in this dried up, and this never went anywhere. I actually just heard a couple weeks ago that this patent's now owned by Billy Cohn with his technology now of connecting two blood vessels together with magnets. But again, it was a great idea. The timing was just wrong. The other concept of just because it's new doesn't necessarily mean it's great. And this is an example of it, of transmyocardial laser revascularization. this falls into the category of, now what were we thinking? Did we really think that this was going to work? But I embraced it, as did a lot of other people, and it's one of the things that I'm not sure what I was thinking at the time. Here's another concept this was a company called Corgentech that had a blocker of upregulation of neointimal hyperplasia. These were the PREVENT-4 trials for saphenous vein grafts. And it was one of those things, if it sounds too good to be true, it probably is too good to be true. And this was an example of, wow, you know, I embraced this wholeheartedly with both arms, and it turned out, in retrospect, we were pretty clueless as to what we were actually doing. So what is going to work going forward? Well, I think we're about to see an explosion in transcatheter mitral valve replacement, and I think it's going to dwarf TAVR over the next 5 to 10 years. It's going to be so much bigger than that. Indeed, just this week, last week, there were 2 new transcatheter valves that were introduced at EuroPCR, Sophia and Nacostech, that I had never heard of before. Of the 5 that you see in this picture, 4 are in humans, and there have now been 15 human transcatheter mitral valve replacements. This is the Tendyne device, the before or after. But the key message here is that all of these, at least in the beginning, are all going to be done transapical. This shows the Tendyne valve that's functioning. And we now have access enclosure devices that are going to allow percutaneous transapical devices. This is the Apica device. So I think that transapical needs to move front and center again, because it is going to be the preferred method of delivering this technology over the next upcoming years. Eventually it'll evolve to transfemoral, but I think as surgeons we need to be front and center figuring out this transcatheter mitral valve replacement by a transapical approach. So what are some things that I wished I had done or could have done differently? Well, I wish I had more expertise in the following areas: business, imaging, trial design, statistics, health policy, as I mentioned, public speaking, and scientific writing. And so there's a number of opportunities to gain those skills that I wished I had stopped and done. I was so busy just working, keeping my head down in the operating room, getting as many cases done as I possibly could. And I think if I had paused and gained another skill set, it would have served me well. And so I think one is going back and getting an MBA, of going to business school. I think is something that has served some of us well. Second is a master's in public health. A lot of what we do is outcomes research and epidemiology. And I know a number of cardiologists that have gone back and gotten masters in public health. And they're some of the major trialists today. Go back and learn about engineering. Now, you don't have to get an engineering degree, but spend time at the biodesign program at Stanford with Paul Yock. And this is a hybrid between the engineering school and the medical school of Stanford. And the folks that have gone through Paul Yock's program and the devices that they have invented are absolutely incredible. Or Tom Fogarty has an Institute for Innovation just up the road from Stanford. And taking time and spending a sabbatical with Tom Fogarty, I mean, he just oozes new ideas. And the way that he thinks is just incredible. Learning about patent law and learning about venture capital and how they think. And there's many law firms and venture capital firms on Sand Hill Road outside of Stanford that you can go spend a sabbatical at and spend, you know, a month, 6 weeks, 2 months, learning how these folks think, learning, you know, what the business environment is. You can have the greatest idea in the world, but if there's not a clinical unmet need, or if you have a difficult path to clinical introduction, there's not going to be money for it, and it's not going to go anywhere. And these folks understand it much better than we do. And then health policy. I think that a lot of what we're going to do going forward, it has to do with health policy and the ecosystem that we're working in. And spending time at the Brookings Institute or the Pew Trust or the FDA Entrepreneur in Residence program. So there's a number of company CEOs that have actually taken sabbaticals and gone to work for the FDA. Tom Fogarty works in the FDA right now, but they've gone through the FDA Entrepreneur in Residence program. Or take a sabbatical and work with CMS to figure out the reimbursement strategies. I mean, that's what Jeff Rich did. And I think that that has served us incredibly well. So there's a lot of opportunities to gain skill sets that I think will serve us well going forwards. So what do all these folks have in common? I think you recognize virtually all the faces right there. They're all surgeons that invented something. They all have a medical device that they invented that have clinical application today. So I think everybody in this room is smart enough, if you just think outside the box, go out and invent something. Because a number of folks that are among us have done that. So my other advice is super subspecialize. I think the days of the generalist cardiac and thoracic surgeon are waning, and that we do need to focus on specific areas as a key to success. And spend 10,000 hours in your chosen endeavor. Go back and read Outliers. I think that unless you spend that amount of time in what you're doing, you will not excel at it. Always think outside the box. Don't have a guild mentality. Just because we're surgeons doesn't mean that surgery is always the right answer. I think we can learn from the cross-fertilization with other specialties. And sometimes, although surgery is good, there's another way that's better, or a hybrid approach is better. Partner with someone. You can't do this alone, and it's always better having somebody either within or without the specialty to do this with. And I think the biggest area of innovation, and it's not sexy and it's not what we classically think of innovation, is innovate the healthcare system around us. Because this is undergoing change like nothing that's happened in the last 50 years. And I certainly think that we need to be a part of it. So this is Michael Porter. The strategy that will fix healthcare, and providers must lead the way. And I must say, in your own institutions, all of you are leaders within your institutions. And I think it's helpful to kind of learn these concepts that are going to change healthcare. And what is happening in the United States is going to spill over outside the United States also. But this is the value agenda of what's going forward. And I learned this term that I hadn't heard before called IPUs. Anybody know what an IPU is? It's an integrated practice unit. What is it? It's the heart team. It's the heart team taken to every other specialty within a hospital. I mean, so this is what's going to be viewed as value going forwards. And so healthcare delivery, which has always been siloed with traditional cardiovascular specialties such as this, is now going to change. And the way that a patient's treatment is currently determined is based upon what door of the hospital they walk into, or what physician's office they walk into. If you walk into a cardiologist's office, PCI is the right answer. A general cardiologist who believes in the COURAGE trial, it's going to be medical therapy. You walk into a surgeon's office, the right answer is CABG. It may be TAVR if you walk in this door, or SAVR if you walk in this door, or hybrid revascularization if you happen to walk into a clinic of surgeons and cardiologists working together. One surgeon may say mitral valve repair, and another mitral valve replacement, and another is MitraClip. Now, look at it from a patient's perspective. Why does that make any sense at all? I mean, certainly we can do a little better job, and that's kind of the value agenda going forward. So I stole this shamelessly from Volkmar when I heard him speak at the 50th anniversary of the program in Zurich a few years ago, of reorganizing your team as service lines, of a coronary revascularization team, a mitral team, and each specialty organized as a multidisciplinary team. And we adopted this. So this is our heart valve team. That's all these folks do now, is take a heart valve therapy. And it's 6 surgeons, 4 interventional cardiologists, and 3 imaging cardiologists, all of which are devoted. But this is something I sat there and listened to Volkmar about the way he was reorganizing things in Zurich to deliver care. Other healthcare system strategies going forwards, as well as a service line and heart team approach, are transparency of quality outcomes and transparency of price, a staff model, physician employment, population health strategies, and employer direct contracting. I think we as leaders in our institutions need to understand all this and understand this language going forward. So comfort is the arch enemy of change and a roadblock to success. And we have to be about change. And I know everybody knows this, but it is worth repeating that, you know, Kodak film served a great service for 100 years. And I understand we heard other examples yesterday of the steel industry, et cetera. But things change, and disruptive technology, a breakthrough may not always seem like a breakthrough to begin with, but it's the refinements or the sustaining technology that happens that creates the value to it. So good enough for our transatlantic friends, but unworthy of the attention of practical or scientific men was the British Parliament talking on Edison's light bulb. Television won't last because people will soon get tired of staring at a plywood box every night. So how wrong those two things were. So it's the 60 years of refinement in portable communication technology that has created the iPhone today. It didn't start out as that by any means. And this was recorded music, a disruptive technology. But look at all the iterations of sustaining technology that have happened to get to this today. This was a disruptive technology. This is the refinements that have happened that has the computing power in your hand that the original IBM MANIAC computer had in 1945. So this is one of the first airplane flights that didn't end well. And this is the first successful one that did well. But look at all the refinements and iterations that went to get to this 100 years later. I remember this very vividly from USA Today in 1993. They panned the internet. They said that the wireless net was so wowless. Now, can you imagine life without the internet today? So this is when I started out in internal medicine, as Francis mentioned, at the University of Minnesota in 1993. And if I just look at the changes of what happened, when you think, look at it every day, it doesn't seem like much changes, but if you reflect back, it does. Acute MI in a hospital was a 1-month stay because there was nothing else to do about it. Surgical hip operations were done, and it took 6 weeks to recovery. There was no such thing as knee replacements. Acute leukemia, there was no cure for. Cholecystitis was an open procedure that took 6 months to return to work. Heart transplants had gone from headlines to abandonment. And believe it or not, there was no specialty of interventional cardiology. And heart valve surgery was rare, and I looked like this. So fast forward, since then what's happened? Mortality from heart disease has declined by 50%. Total hip replacements are routine. Bilateral knee replacements as an outpatient procedure are routine. Most leukemia is now cured. Lap chole is an outpatient procedure. Heart transplants and VADs are now routine. And we have percutaneous heart valve therapy, and I got a haircut. So the world is a dangerous place, not because of those who do evil, but because of those who do nothing. So control your own destiny or somebody else will. Thank you very, very much.
Do you have any questions? It's a great opportunity to get some questions going. Total.
Or comments?
Or comments? Everyone's got total knowledge. Here's a question. All right, excellent.
Dr. Mack, I have a question for you. At so many of the meetings in the last 10 years, the focus on transcatheter therapies has been one of acquisition of skill set. And for those of us younger guys who were actually very well trained in endovascular skills, we have not found that to be the rate limiter. The rate limiter has been the fact that we are cardiothoracic surgeons. We are fully capable of doing a MitraClip, a transcatheter valve, virtually anything. But in many institutions, the problem is not the skills, it's the politics, it's the credentialing, it's the perception, which can all be sort of summed up by when we did our first TAVR about 6 months ago at our organization, a young cardiology fellow asking the question, why is there even a surgeon here? Can you answer that?
Sure. You bring up a very real and difficult issue. And the first thing is all politics is local. And, you know, nobody can solve local politics except you yourself. And I think that there's a couple answers to this. So first of all, where we are in cardiac surgery is exactly where the vascular surgeons were 10 years ago. And they changed. They adapted. And they now control, for the most part, endovascular therapy. And the majority of procedures done now are endovascular and not open. But the difference between them and us is they controlled the patients. So they, although we're at the same place, they had their own patients. Well, I said I learned some lessons. So who controls the patients at our institution now? It's us as surgeons. And so we do have multi-specialty clinics. The thing that I beat into our younger folks is get out of the operating room and be in clinic. Don't surrender that to the cardiologist. If you want a seat at the table, you got to be at the table. And so it's finding somebody within your institution that you can develop a good collaborative relationship. Not a young cardiologist who thinks that they own the world, but somebody that you can work with and develop a relationship and do this together. As I mentioned, all this is about to come back around to transapical right now, okay? So don't be the surgeon that is over in the corner on his iPhone during a transfemoral procedure because a cardiologist thinks they can do this without it. Take that advantage of working together, develop a collaborative relationship, being in clinic, going to a transcatheter valve meeting with that cardiologist and developing that relationship. I'm not minimizing by any means. I know exactly what you're talking about. But I think we have to develop an adaptive strategy in this environment because this is deja vu all over again. But I think if we kind of learn how to play the political game correctly and use to an advantage the skill sets we have from all aspects of it, then it can be successful. And it's not going to be successful anywhere. But I think the institutions that have embraced this and done this well, from, have done it well, have thrived, from Greg Fontana and Raj Makkar, from Vino Tharani and Vasilis Babilaros, and Joe Bavaria and Howie Herman, again and again. I think if you go to Edwards or Medtronic and ask them the programs that are most successful, it's where the surgeon and the cardiologist work together with it. Again and again and again, that's seen. And I know a lot of folks are from outside the United States, and I'm totally aware of what's happening in Germany and the political fights that are going on there to try to keep this all constrained and everybody playing nice in the sandbox. But I think that if you, within your own institution, if you work hard on developing the right paradigm and finding the right people that you can work with and that are willing to work with you, then that's a key to success.
Thank you very much. Thank you. That was an awesome address, and I want to thank Dr. Mack again for his leadership in the field. And sometimes we do take for granted, relationships count. And building those relationships is incredibly important. Next, we're very fortunate again to have Dr. Davy Chang. Dr. Davy Chang, as many of you know, has really helped us with our consensus statements. And